Hi class, this is Miss Mickens, and we're going to be going over a review of some information that we learned when we learned about preeclampsia earlier in class. We're going to be reviewing signs and symptoms, labs, and treatment. Let's start with a review of exactly what preeclampsia is. Preeclampsia is a condition during pregnancy in which a woman experiences elevated blood pressures and proteinuria. When we look at what is an elevated blood pressure exactly, we already have learned that typically that is a blood pressure reading of at least 140 over 90. However, in pregnancy, we've also learned that a diagnosis of elevated blood pressure could also be an increase over baseline of 30 systolic, 15 diastolic. Why is that important, you may ask? When we look at a reading such as that one, that means a woman whose baseline was originally maybe 90 over 40, if they have an increase in blood pressure of 120 over 55, which is typically outside of pregnancy, considered a totally normal blood pressure, would now, if she is also spilling protein into her urine, considered preeclamptic. At minimum, with the absence of protein, she would at least be considered gestational hypertension with a blood pressure well below 140 over 90. Let's take a closer look at that. You received a handout during class that pretty much mimics what you see in front of you. It actually outlines the progression that we may see of a woman's blood pressure during pregnancy. So we already learned that if a woman already has blood pressures or elevated blood pressure readings prior to pregnancy, that's considered chronic hypertension. And that's typically a reading of at least 140 over 90. A lot of times these patients do not spill protein in their urine. However, after they become pregnant, they might. At that point, we don't just consider them chronic hypertension, we actually consider them superimposed preeclampsia. And you see that is that progression as we move over. Then when we look at gestational hypertension, typically this is a diagnosis that is for women who did not previously have blood pressure issues prior to their pregnancy. A lot of times with gestational hypertension, remember we see this increase in their blood pressure after 20 weeks. And that would be a blood pressure reading greater than 140 over 90, or again, that increase over baseline of 30 systolic, 15 diastolic. So preeclampsia, which is our focus in this particular presentation, is going to be everything that we see with gestational hypertension. Plus, we now have the presence of protein in the urine. That is going to be the big differentiating factor between preeclampsia and gestational hypertension. Now, we know that preeclampsia can become progressive. And when we look at that, once a woman has a seizure, she would be considered having eclampsia, no longer preeclampsia. And then we know that even in the absence of seizure activity, this particular disease process could actually progress further, in which we talk about HELLP syndrome. And when we look at HELLP syndrome, we know that's hemolysis of the red blood cells, elevated liver enzymes, and low platelets. We're going to talk about that a little bit further in this presentation. Let's review some of those risk factors for a person to develop preeclampsia. Well, if it's their first pregnancy, they actually have an increased risk of having preeclampsia with that particular pregnancy. If they are obese, have a family history of gestational hypertension. When we look at age factors, if they are younger than 19 years of age or if they're older than 35 years of age. Typically, we think that the majority of risk factors in pregnancy are associated with those who are over 35. In this case, also younger than 19 increases the risk of developing preeclampsia. If they have a multifetal pregnancy, saying that they are pregnant with at least twins or maybe triplets or quadruplets, if they already have chronic hypertension, definitely if they have chronic renal disease, and also if they have diabetes mellitus. Let's look at those signs and symptoms. So when we look at it, it could be things like edema, headaches, blurred vision, double vision, or seeing spots, brisk deep tendon reflexes, proteinuria, oliguria, epigastric pain, pulmonary edema, or seizure activity. And of course, once they have a seizure, they're no longer suffering from preeclampsia. They're going to now be considered as to have eclampsia or be eclamptic. But let's take a closer look at these signs and symptoms and how they relate to the various systems of the body. These are very important to recognize when you're performing that head-to-toe assessment of your patient. So we always have to keep these in mind, as the presence of a lot of these signs and symptoms could indicate worsening of the disease. So let's look at these. Edema typically occurs because fluid is leaving the cells and entering the tissue. That's why we see these women a lot of times suffering from pitting edema. Headaches a lot of times are related to the elevated blood pressures, which we know we see in people with chronic hypertension. We're always warning them about the presence of headaches when they have blood pressure issues. We also know that the presence of a headache could indicate cerebral edema in these ladies. When we look at the visual changes, there could be arterial spasms occurring or retinal edema. With these increased deep tendon reflexes, that is typically indicative of a central nervous system irritability. And we know if we don't do anything about it when we see those deep tendon reflexes becoming more and more brisk, ultimately this woman is at risk of having a seizure and becoming eclamptic. When we look at proteinuria and oliguria, again, during this process of preeclampsia, there's decreased blood flow to the kidneys. And we also know that if you have high blood pressures, that can be very damaging to the kidneys and how they function. When we look at epigastric pain, which is typically right upper quadrant pain, we know that's typically associated with the hepatomegaly or swelling of the liver. Let's take a closer look at some of these labs that are drawn. When we look at a lot of times women who are suspected of developing preeclampsia, or if we wanted to actually look at how well her management is going, doctors may order things like a CBC with DIF, a CMP, 24-hour urine, a protein and creatinine clearance, typically with that 24-hour urine. And let's think about this. Let's look at some of the things that may be included in a CBC with DIF. Or let's ask ourselves, why would a doctor order a CMP over a BMP? Well, when we look at the laboratory values, we know that a CBC typically includes a hemoglobin and hematocrit and platelets. And of course, the hemoglobin and hematocrit will indicate the presence or possible absence of hemolysis of the red blood cells. And platelets will let us know if this patient is experiencing thrombocytopenia, which could also be suggestive of gestational hypertension, but more importantly, of HELLP syndrome when we look at those low platelets. When we look at urine for protein, of course, proteinuria confirms gestational hypertension and can be used to differentiate preeclampsia from severe preeclampsia. When we look at the serum creatinine, we know that elevated creatinine is indicative of renal damage, so is elevated serum uric acid levels. And then when we look at the serum transaminase, we know that that can be an indication of involvement of the liver. So going back to my earlier question, why would a doctor order a CMP over a BMP? Well, we know that this is a disease that can impact the kidney and the liver. So when we look at kidney function, we also need to look at liver function, because remember, we're going to be looking for the potential for developing elevated liver enzymes. So speaking of that, let's talk a little bit more about HELLP syndrome. So remember, HELLP syndrome is a dangerous complication that can develop during preeclampsia. And we know that it is marked by hemolysis of the red blood cells, elevated liver enzymes, and low platelets. And we need to be on the lookout for that. These women may feel a little worse, but they may not feel significantly worse. So we have to keep a close eye on those lab values. So why is this occurring? We look at the hemolysis of the red blood cells being caused by erythrocytes breaking up as they're passing through these damaged hypertensive vessels. And why do we have the elevated liver enzymes? So we know that the hepatic flow is going to be obstructed, which is going to cause our liver enzymes to go up. And then when we look at why am I experiencing low platelets or seeing low platelets in these women, it is going to be the platelets that are aggregating to address the damaged vessels, and that's going to cause an overall decrease in the number of platelets that are available. So of course we need to know, how do we treat this? So let's talk about some of the medications used for treatment. So we know that the two main medications used are either antihypertensives and anticonvulsants. So some of the most popular medications are hydralazine, labetalol, and nifedipine. All of those are going to be antihypertensives. When we look at labetalol, it can be given PO or IV, and nifedipine, while actually considered a blood pressure medication in pregnancy, we know it can also be used in preterm labor as a tocolytic. And then when we look for the anticonvulsant, that is going to be magnesium sulfate. That is going to be our major medication given to decrease the likelihood of a woman having a seizure. Again, don't forget, the primary reason for magnesium sulfate is not to lower the blood pressure. It is to increase the threshold for seizure activity so that hopefully she does not develop eclampsia. Now, when we give magnesium, we do have to be mindful that there are risks for the woman developing magnesium toxicity. So we again need to be very vigilant in our assessments. So magnesium toxicity can occur if serum magnesium levels exceed the therapeutic range of 4 to 8. And we know that signs and symptoms of magnesium toxicity include absence of deep tendon reflexes, respirations less than 12, urinary output less than 30, and definitely could be indicative of magnesium toxicity if their serum level is above 8. For that reason, we have to remember calcium gluconate. Calcium gluconate is, of course, the antidote for magnesium sulfate. Calcium gluconate should be readily available whenever magnesium is being administered. So again, if you're concerned about magnesium toxicity, you're going to give calcium gluconate to reverse those effects. Let's review with a couple NCLEX questions. So which of the following are manifestations of preeclampsia? And it is a select all that apply. Glycosuria? Well, it's not glucose in the urine. Ooh, blood pressure of 150 over 100. Definitely. Left upper quadrant pain. You got it. It's right upper quadrant pain, so that's not one. Proteinuria? Absolutely. Epigastric pain? That's that right upper quadrant pain. Good job, guys. Next one. Looks like we skipped one. Let's go back. Looks like the nurse is caring for a client diagnosed with preeclampsia. Which of the following best indicates why magnesium sulfate would be ordered for this client? You got it if you said D, to prevent seizures. And then our last question, the nurse is caring for a client who is believed to be developing HELLP syndrome. Which labs would the nurse anticipate the doctor ordering? With this one, we would say a CBC with diff. BMP, again, we would prefer a CMP for this one, a CMP, because that will let us know about those liver enzymes. These are my references. So this is the book from which we learned everything initially about preeclampsia. I hope you enjoyed the presentation, guys.